The Salem Physiotherapy Association done appa.
Okay, sir, we are live now.
Okay.
Please start.
Good evening, all. Welcome back to For the Students, by the Students program organized by ExRxIndia and associated with Pickle Studio, Sairam Academy, Sri Samraj Health Services Private Limited, Sri Samraj Physiotherapy Center, and DUSAT Creations from West Bengal. And now we are having our guest for the inauguration of this session. Last session he came a little bit late. So now we are having Dr. Sendil Kumar, President of Salem Physiotherapy Association. I request Dr. Sendil Kumar give us blessings and give us students a speech.
Hello.
Yes, sir.
Very good evening to one and all. I am very happy to meet you all through this webinar. This is a great saying. The art of teaching is the way of assisting discovery, which means teaching itself is equal to a discovery. By teaching, one discovers great knowledge into the subject, acquires mastery, and develops new worries. Really, I appreciate the organizers who have initiated this continuous webinar and a world record also. Yeah, have found many good teachers and teaching methodology. Once again, I congratulate them. Great success in future. All the best to all. Thank you.
Thank you, sir.
Great opportunity.
Thank you so much, sir, for a short and sweet speech. Because we are going live again, and now today's second topic is in quick interpretation of PFT and ABG by Dr. Hiral Jain, MPT cardiovascular student, and he is from CMF Pune. Now I request Dr. Hiral Jain to start her session.
Thank you, sir, for the wonderful introduction. Before beginning the session, I would like to thank Chandramohan sir and the ExRx team for this opportunity, and Duna ma'am, Rupesh sir for always being patient and supporting us. And also my principal and my college teachers for allowing me to accept this opportunity. So here to begin with our second topic, after such a wonderful session by Dr. Bhuvna Lakshmi ma'am. My topic for the day is quick interpretation of ABG and PFT. Before beginning, first we will be understanding what is PFT and how it will help us and where it can be used, and also about its contraindication. Okay. So introduction, basically pulmonary function test includes various tests in it like plethysmography and spirometry, and we will be discussing more about spirometry in this session. The first, as it is said, the term PFT encompasses a wide variety of objective tests to assess lung function. It's a objective and standardized measurement for assessing the presence and severity of respiratory dysfunction. Spirometry is the cornerstone of all the PFTs because it is a bedside test, and also it is can be easily performed, and no extensive training is required in it as compared to the others. John Hutchinson invented spirometer. He said that a spirometry is a medical test that measures the volume of air an individual inhales or exhales.
Hiral, your audio is very low, Hiral.
Yeah, okay, sir. I'll repeat.
Yeah, now it is fine.
Spirometry is simple and clinical based test used to measure airflow and lung volumes during a forced expiratory maneuver performed from full inspiration. It is a measurement of single forced expiration from total lung capacity using spirometers. Spirometer is the test used, and what spirometry can do is it can measure vital capacity, forced expiratory volume within 1 second, and peak expiratory flow rate. And it cannot measure the residual volume and the capacities which contain the residual volume. Like the FRC, the components of FRC are the ERV and the RV. So therefore, it cannot measure the functional residual capacity also, and the total lung capacity is the sum of all the volumes, which includes the residual volume. Therefore, it cannot measure the total lung capacity. Now, before going ahead, we'll understand where can the PFT can be used. It can be used as a diagnostic and a prognostic purpose. In diagnostic, it can help us in evaluation of the signs and symptoms like the breathlessness, exertional dyspnea, chronic cough, and also it can help us to predict the presence of pulmonary dysfunction as to whether and to know the functional nature of the disease, whether it is an obstructive or restrictive condition. And for the pre-operative assessment, like we for any fitness surgery, prior to it we check for fitness. So in that also, for checking the respiratory system fitness, the PFT can be performed. And using PFT as a prognostic component, it can be used as for assessing the degree or severity of the disease, to assess the progression of the disease, and to assess the response to the treatment. As to the treatment protocol which we are giving, which we are following to the patient throughout during our treatment sessions, is it going in a positive direction or a negative, or there is no effect of our treatment? So PFT can be used as an outcome measure over there. And going to the contraindications, hemoptysis of unknown origin is one of them, and unstable angina pectoris, myocardial infarction, is completely contraindicated. Recent thoracic and abdominal surgical procedures, they are contraindicated because if there is any pressure over the suture site, it can be a problem. Therefore, recent thoracic and abdominal surgical procedures are contraindicated. And recent eye surgery, because if due to forced exhalation, there will be increased intraocular pressure, which will cause damage to the retinal vasculature. And going to the next, that is history of syncope associated with forced exhalation. Syncope here means that unconsciousness due to fallen BP. Because of forceful exhalation, there will be less oxygen supply to the brain. Because of there are chances of syncope to occur. Now, before going ahead and understanding the interpretations, first we'll identify what do we get on the what do we get at the end results, and how do we classify the conditions. Those conditions can be classified as obstructive and restrictive. So what do we mean by obstructive? Obstructive is the condition in which the patient has a problem in exhaling, and there is air trapping present, as written over here on the slide, characterized by limitation of expiratory airflow so that airways cannot empty as rapidly as compared to normal, such as through narrowed airways from bronchospasm, inflammation, etc. Examples of this are asthma and emphysema. And for the restrictive, what are restrictive disorders? In this, the patient is unable to inhale. There is it is characterized by reduced lung volumes or decreased lung compliance. And the examples are interstitial fibrosis, scoliosis, obesity, lung resection, and neuromuscular disease. For this, explaining with the example, taking our old normal socks, which is old, which you have used for prolonged period. Okay, so that has become loose. Once you expand the rubber part, you expand it, it is expands, but it does not comes back. That means it is reduced recoiling capacity, which comes under the obstructive condition. It means that in obstructive condition, there is high compliance, high extensibility, sorry, but it is low recoil capacity. Whereas in restrictive, it can be considered as a new socks that is in which the rubber band or at the top is is very tight but not easy to expand. So which means that is decreased compliance and increased recoiling capacity, but decreased compliance, that is less ability to expand. Okay. And another example you can use is a rubber band, normal elastic rubber band, which if you stretch within the elastic limit, it will be easy to expand. But when you expand it beyond the elastic limit, entering the plastic limit, there will be a permanent change. So that will be an obstructive, and within the restrictive elastic limit, that will come under the restrictive disorders. Okay. So now going to the prerequisites, that is what are the main criteria which we have to follow before performing the PFT. That is, which includes prior explanation to patient, what are the procedures they should follow. That is to not smoke or inhale bronchodilators 6 hours prior or oral bronchodilators 12 hours prior. Ask them to remove any tight clothing, vest, belt, or dentures. Patient should be seated comfortably. And if obese child, less than 2 years or 12 years, sorry, they should be in standing position. Now going to the next slide is regarding the procedures. Okay. In the procedure, as we can see in the image here, there's a patient with the nose clip on the nose and a PFT machine in the hand, PFT device in the hand, and the computer in which the recordings will be recorded. And in this, the first is the height, weight, age is documented. Then the patient is given a comfortable sitting position with back fully supported, and the nasal clip is attached. Then the patient is asked to take in deep breath and do forceful expiration. Then, followed by subject blows air in the mouthpiece of the spirometer. The expiratory effort of the patient will be displayed on the screen. And thus, as in the other further slides, we'll study the parameters which will be recorded. Before seeing the parameters, first we'll understand how the PFT has been documented. First is the point of type of abnormality, as in whether it is an obstructive condition or a restrictive condition. And second, degree of affection. It can be classified as mild, moderate, and severe. As we can see on the slide on the right-hand corner, the yellow box, in that the degree of affection is classified as per mild is based on the ratio FEV1 by FEC, which lies between 60 to 80%, whereas in moderate, it lies between 40 to 60, and anything below 40% will be considered as a severe degree of affection. Then the next point comes, that is the type of obstruction. It can be classified as, first we identified the obstructive, whether the condition is obstructive or restrictive. Now comes whether it is a pure obstruction or the condition has a signs and symptoms of both obstructive and restrictive, which is the mixed obstruction. And the next point, involvement of airways, whether the smaller airways or the larger airways are affected, we'll understand that. Then fifth is the respiratory muscle condition. Then the sixth, after all the parameters are being judged, then to check whether the condition is reversible or the condition reversible, we'll give the bronchodilator response. We'll check for the bronchodilator response. Now going to the interpretation of PFT, systematic and stepwise approach. These are the 7 steps. First step is to first check the, likewise we saw in the previous slide, that first is to identify whether it is a obstruction or restrictive condition. So that can be identified using this ratio. That is the FEV1 by FEC ratio. If it is normal or equal to more than or equal to 80% of predicted value, then it is normal. If it is it is less than 80% of the predicted value, it can be classified as obstructive and restrictive. And the second is determining the severity of affection, mild, moderate, or severe. As we saw in the previous slide, the levels, which is mild for 60 to 80, then moderate is 60 to 40, and then severe is less than 40. Step 3 is observing the FEV1. The normal value is more than or equal to 80%. And step 4 is the forced vital capacity, which is normal, is more than or equal to 80% again. Then step 5, FEF 25 by 75%. Normal is more than or equal to 60%. It will help us to identify whether the affection is present of the smaller airways. Like we saw in the previous slide, one of the component to measure is whether there is affection of the smaller or the larger airways. So from FEF by 25 to 75, we'll get to know about the smaller airways affection. Then step 6 is the PEFR. And PEFR, the normal value is more like 60%. It will help us to comment upon the larger airways affection involvement. And the last one is the maximum maximum voluntary ventilation. And the normal value is 160 to 180 liters. It is used for preoperative fitness. Okay. Now we'll understand how are these parameters affected in the obstructive and the restrictive disorders. In the obstructive disorders, the ratio will be reduced. And the FEV1, that is forced expiratory vital volume, forced expiratory volume, in 1 second, the page is reduced. And the parameter that of the ratio FEC will be normal or reduced. That is, it will be either 80 or less than 80.
FEF 25 by 75% will be reduced, and total lung capacity will be normal or increased till the that is more than 120%. Now, as we studied in the previous slides, that pure it can be further classified as pure obstruction and mixed obstruction. Hello. Okay. It can be further classified as pure obstruction and mixed obstruction. Okay. So in pure obstruction, the only unique feature will be the FVC ratio. Parameter will be normal. Other two parameters, that is the ratio and the FEV1, will be reduced. So the strike. So the hello. Okay.
Kindly remove the person, please. Kindly remove that person, please.
Sir, I'm trying to.
Okay. So again, I'll repeat. The unique feature between pure obstruction and mixed obstruction will be that in mixed obstruction, all the three parameters, here the major parameters will be reduced, and in pure obstruction, only the FVC parameter will be normal. The other two parameters, which is the ratio and the individual FEV1 value, will be decreased. This will be the unique remembering key factor. And in restrictive disorders, the FEV1 and FVC ratio will be normal or increased. And in FVC, it will be reduced. And the since FEV1 is the numerator and FVC is the denominator will be reduced, but the FEV1 will be normal or equal to 80% of the predicted value. Therefore, it will the ratio will be normal or increased. FEF 25 by 75 will be normal or decreased. That is, there will be affection of the smaller airways, and the total lung capacity will be reduced. Everyone's okay?
Continue, Hiral.
Yes, ma'am. Now continuing with the flow volume loop. What is the flow volume loop? On the right hand side, as we can see, there is a flow chart. In that, the vertical axis denotes the expiratory volume, expiration, and the horizontal axis, where I have written the volume part, it is the it will denote the inspiration. And also this loop can be divided into two parts. The upper part will be expiratory and the lower part will be inspiratory. Okay. Above the baseline, it will be expiratory, and below the baseline, it will be inspiratory. What are the characteristics of this loop? Basically, the normal expiratory curve, as we can see, it starts from 0, and there is a peak point where it is the highest. It will be termed as peak expiratory flow rate. Beyond that point, there is a smooth descent and a straight line. Okay. And if we test this PFT and check in a normal person, in a normal lung with normal respiratory muscle strength, so it will be denoted as a triangle sitting over a semicircle. Okay. This contour of the loop will assist us in diagnosis and localization of airway obstruction, as different lung disorders produce distinct patterns. For that, we can see in the left hand side graph, that is figure A. Okay. Okay, this is the normal one. As we can see, this is a triangle on the semicircle. This is the horizontal line, horizontal axis, which will be presenting the inspiration, and the vertical axis will be presenting the expiration. This is the 0.0 from where it starts, and this is the peak, PEFR, point of PEFR, and there is a smooth descent, straight line. Okay. Now, in obstructive condition, that is the figure B, sorry. As we can see in emphysema, there is a scooped out appearance in the expiratory phase because there is obstruction, air trapping. The patient is not able to exhale. There is air trapping inside, so there is scooped out appearance. This part. After the peak point is reached, there is a scooped out appearance. There is a concavity. As the disease progresses, PEFR becomes more prominent and reduced. Okay, and for restrictive conditions, we can see the figure 6. The loop's shape and size will be same to the normal one, but there will be decrease in size and height. This one. restrictive parenchymal lung disease. Okay.
Continue, Hiral. Any problem?
Yes. No, ma'am. In pre and post, next we can check about regarding the pre and post bronchodilator response. It is done after the PFT values is measured. First will be it is to investigate the reversibility of the disease. In this, what we do is patient is given nebulized bronchodilator and PFT is taken 15 minutes after bronchodilator therapy. Then the pre and post parameters are compared. This test will be said to be positive when the patient meets the following criteria. That is, the ratio will be increased from the pre-bronchodilator parameter by 12 to 15%, and the individual forced expiratory volume in 1 second will be increased again by same 12 to 15%, and the forced vital capacity will be increased by 12 to 15%, that is 200 ml, and the PAFR will be increased by 20%. The FEF 25 to 75% will be increased by 30%. Okay. Before going ahead, I would like to say more about restrictive condition, in which there is usually a confusion that if the ratio is normal, then the if the ratio is normal, then FEV1 or FVC values will suggest restriction, because there will be decrease in the value. Also, there will be confusion in restriction that the ratio is normal. Then how do we how do we confirm that it is restrictive condition? That can be due to intrinsic function. Due to intrinsic factor or extrinsic factor. Intrinsic factor like the lung disease, the lung is itself is affected, or extrinsic factor like the thorax, there is muscle weakness or chest wall deformity or nerve damage. For that, we can use the flow volume loop, which we recently understood, that there will be if the flow volume loop. Okay. Then if the ratio is normal, uh, how do we classify basically? There will be reduction in the total lung capacity present. And we can check with the flow volume loop, because the shape and size was decreasing in the restrictive condition. And based on the bronchodilator response, how will we distinguish between whether it is COPD or asthma? We can do it with the bronchodilator therapy, giving a bronchodilator if the ratio FEV1, if the FEV1 increases and there is a improvement in the value that is increased by 12 to 15%, then it will be a reversible condition and it will be a asthma. If there is no improvement, there will be no change in the FEV1, and this will be signify that it is COPD. In brief, that is that reduction in ratio, it will be obstructive lung disorder, and low total lung capacity will be restrictive lung disorder, and increase in ratio will be restrictive lung disorder, whereas decreased ratio plus the low total lung capacity will give us a picture of mixed lung disease. Okay. Now going to the ABG. Before going to the ABG, these are the small examples. I would like to explain it to you. As we can see, the FEV1 by FVC ratio here is reduced. That is, normal was 80%, and individual value of FEV1 is 56, which is against reduced, and FVC is normal. It is normal FVC, so it gives a picture of a pure obstruction. As we saw that if all the three parameters, that is the ratio and the individual FEV and FVC were reduced, so it was a picture of mixed obstruction. And when one, that is FVC, is normal and the other two parameters are reduced, then it will be a picture of pure obstruction. Further looking at the parameters, that is the PEFR, which is normal, so there is no affection of the larger airways. Then here comes FEF 25 to 75%, which is reduced because normal was 60%. So there is presence of smaller airways affection. And also regarding the post bronchodilator response, which was checked, if it is 15% more increased, then it is it denotes that there is a good reversibility of the condition. With the second example, that is the ratio is 48, which is reduced, and FEV1 69, which is again reduced. Okay, because the normal was 80 more than or equal to 80% of the predicted value, and FVC is again reduced, that is 75. Okay, so this gives all the three pictures are all the three parameters are reduced, therefore it gives a picture of mixed obstruction. Then we go to the other parameters. Here again the PEFR is normal, so there is no affection of the larger airways. And then FEF 25 by 75, 25 to 75% is equal to 60%. Again, it is a no affection of smaller airways too, and a good bronchodilator response. Then the third example, which is the ratio is increased or normal or increased, okay? And the individual parameters, whereas FEV1 is normal and FVC is 65. So this denotes that it is a restrictive condition, okay? And PAFR is equals to 48%. There is reduced, PAFR is reduced. So it will be affection, presence of affection of smaller, larger airways. And also there is FEF 25 to 75% is equals to 58, which is also reduced. Again, there is a presence of smaller airways affection and good bronchodilator response. Before moving ahead, I would like to show the how the report is seen. 1 second. Yeah. This is the report. As we can see, the FEC value here is this is the pre-value and percent predicted value. Here we see these parameters, the percent predicted parameters, which is 82. If you can, I'll zoom it. Okay, as we can see, FEC is 82 and FEV1 is 80. Again, both the parameters are in the normal range, and the ratio, which is not mentioned, but as we can see, FEC and FEV1 are in the normal range, the ratio will also be in the normal range, and there is no affection of FEF 25 to 75%, it is 75. There is mild affection of the smaller airways. Then comments, we can see this spirometer meets the ATS criteria and the lung volumes are within the acceptable. Plethysmography were acceptable and repeatable. All the maneuvers were performed acceptably. Spirometer is within normal limits with no evidence of obstruction. Okay. Everyone's clear with PFT?
Hiral, your voice is not clear.
Ma'am, now?
It's clear now.
Okay, sir. So now we'll begin with arterial blood gas analysis. The objective of this session will be that everyone should be able to determine at least that the ABG values are within the normal range. Second, the primary acid-base disturbances and mixed disorders when examining arterial blood gas values. And third will be whether compensation has occurred when examining the arterial blood gas values. And fourth is whether hypoventilation or other causes are the major mechanisms contributing to hypoxemia. Arterial blood gas samples provide information about two main issues, which is the acid-base status of the arterial blood, and the second is the oxygen and carbon dioxide levels in the arterial blood. Then interpretation of arterial blood gases to determine the primary acid-base disorders and alveolar ventilation primarily involves mainly looking at these three components. In the entire session, now ahead, we'll be looking only mainly at these three parameters, that the arterial pH, HCO3 and the PaCO2 values, okay? Because this will help us to identify whether the condition is a respiratory or a metabolic condition and whether it is an acidic or alkalosis. Before moving ahead, I would like to explain regarding the acidosis, what is acidosis and what is alkalosis. As we all know that pH is a 14-pointer scale in which 7 denotes the neutral point and below 7 denotes acidic appearance, and above 7 gives us the appearance of alkalosis, alkaline nature. And then what is the relationship between pH? That is with the PaCO2 and HCO3. pH is directly proportional to HCO3, whereas pH is inversely proportional to PaCO2. That means when PaCO2 is increasing, there will be decrease in pH. And HCO3, when it is increasing, there will be increase in the pH values also. Balance between acid, that is the sulfuric, carbonic, acid or acetic, and base, bicarbonates, phosphates, they determine the pH of the blood. When there is an imbalance between either the acid or the base, the body will try to compensate by changing the other component in the same direction, which is known as the compensation. Okay, the organs responsible for it are the lungs and the kidneys. Now moving ahead, what are the parameters and the normal values which we'll see in the report? Those are the pH, PaCO2, PaO2, HCO3, and base excess to determine the result from the report. Basically, so pH will be in the normal range of 7.35 to 7.45. And PaCO2 will be in the range of 35 to 45. The hint over here is, if we remember the range of 35 to 45, it will be, you can remember that PaCO2 is the same range because 7 is the constant number. So PaCO2 and pH are in the same number. Then PaO2, the range is from 80 to 100, whereas HCO3 is 22 to 25 m equivalent per liter, and base excess ranges from -2 to 2 milli equivalent per liter. Okay. Now, steps for reading the report. It is a quick report interpretation. That is, first we'll check for the pH, which will give us the identification of whether it is an acid or a base. And the second, identifying respiratory or metabolic, which can be identified using the if it is a respiratory component problem, then it will be a PaCO2 which will be altered. And if it's a metabolic component, then HCO3 will be the parameter which will be altered. And to confirm whether it is a metabolic or respiratory, we can see the base excess. If the base excess is altered, then it will be a metabolic problem. Okay, then we'll check for the level of compensation that we'll study ahead. And then the fifth step is the PaO2 level of interpretation. Okay, for that we'll see the next slide. Sorry, next. And on the basis of classification, there are mainly two classified: acidosis and alkalosis. It can be respiratory alkalosis or respiratory metabolic alkalosis, whereas respiratory acidosis and metabolic acidosis. In respiratory acidosis, the PaCO2 will change and the HCO3 will be unaltered. As we said earlier, that PaCO2 will be changing, increasing or decreasing. Then it will be a respiratory parameter which is altered. Then for metabolic, HCO3 will be the parameter which will be altered. And to confirm whether it is a metabolic, the base excess will also be altered. We can check for that. And now we'll study regarding the PaO2 level of interpretation of PaO2 level. That is, the normal range was between 80 to 100. Okay, so anything above 100 will be considered as hypoxemia, hyperoxygenation basically, sorry, which it can occur only when the person is on ventilator or any other external form of O2 support. Okay, and anything less than 80 will be considered as hypoxemia, the smaller circle. And anything between 80 to 110 will be considered as normal. And then if it is reduced between if it is less than 80, so there is a range. If it's between 60 to 80, it will be considered as mild hypoxemia, whereas if it is between 60 to 40, it will be considered as moderate, and anything less than 40 will be considered as severe hypoxemia present. Now we'll understand regarding the phases of compensation. Any acid-base disturbances which occur in the body, it will pass through the three phases of compensation. That is, first, the uncompensated and the acute phase, and the second is partially compensated, and third is the fully compensated. Now, how will we classify them? For that, you have to just look on the main parameters. As I earlier said, that only the three main parameters which will look ahead are the pH, PaCO2, and HCO3 parameter. These three parameters are the main. So in uncompensated acute phase, there will be the pH will be in the normal limit, and the PaCO2 or HCO3. Any one of these parameters will be altered. If PaCO2 is changing, the HCO3 will remain unaltered. That is, there will be no change in the HCO3. And if HCO3 will be changing, then PSO2 will be not altered. Okay. And then going to the partially compensated, that is the subacute phase. In that, the pH will be near to normal, not normal. That is, if we consider 7.35 to 7.45 as the normal range, and the peak point as the range, if it's near to normal, as in 7.34 or 7.46, it is near to normal, but not in the normal range. Okay. So in this subacute phase, both the parameters, that is the PaCO2 and HCO3, both will there will be changes seen, but there will be in the same direction, but unequal proportion. Saying in terms of number, if the PaCO2 increases by 4, that is, the range was 35 to 45. If PaCO2 increases by 4 points, that is 49, the HCO3 will also increase, that is from 25 to, it will increase to 23, but there is unequal proportion increase, that is PaCO2 was increased by 4 and HCO3 was increased by 3. So there is unequal proportion. Okay. So that will be considered as partially compensated. And for third, that is fully compensated, pH will again come back to normal, and both the PaCO2 and HCO3 change will be in the same direction, but now with equal proportion. This is the distinguishing feature between partially compensated and the fully compensated. Okay. This is the summary. And now the small example, not calling it a test. That is, for example, first one in which the pH is 7.35, which is normal, and the PaCO2 is 38. That is within the normal range. That because PaCO2 range was 35 to 45, so it is within the normal range. And HCO3 here is 20, which is reduced. 22 to 25 was the normal, so HCO3 is reduced. So here we can think of that it can be a metabolic component. Okay. So base excess, it is, we'll see the parameter next, that is base excess, which is also reduced, that is less than which is increased basically -2, it is -1.5, because the range was -2 to 2. Okay. So we can term it as metabolic acidosis, because 7.40 can be considered as a peak point, beyond which you can consider that below that you can consider as going towards acidic, that is 7.36, 7.737, 7.38, 7.39. You can term in that manner. So this is a metabolic acidosis with mild hypoxemia. Okay, because PaO2 is 75. And in the second example, that is pH is 7.42, which lies in the normal range. And the second parameter, PaCO2 is 33. That is again reduced. And HCO3 is also reduced. That is 20. And but here we get confused. Now what it is whether it is respiratory or metabolic. So we'll check for the base excess. Since the base excess is normal, that is -2 to 2, it can be termed as respiratory alkalosis. Because again, as we said earlier, 7.40 is considered as the main point beyond which you can classify as going towards acidic or going towards alkalosis. So here it can be said that 7.40, 7.41, 7.42, it is going towards alkalosis. Okay, because it is going towards 8, 9, 10. So this can be termed as respiratory alkalosis. And since it is also increasing, HCO3 also is altering, but it is reducing. Both are reducing in the same manner. With the number in the seeing in the number parameter, both are decreasing by 2. So it is a fully compensated by the it is fully compensated by respiratory metabolic acidosis. In compensation, whenever if there is if like in this condition we said that it is respiratory alkalosis, so it will be compensated by the other part of the body system, that is the metabolic component, metabolic acidosis, to maintain the balance. Just like the homeostasis that maintains the internal temperature, just like that, to maintain the acid base balance, the other component of the body will system of the body will try to maintain by compensating it. Thank you.
Very good session, Hiral.
Thank you, sir.
We will take questions, 2 or 3 questions. Rupesh? Vairav? Unmute Vairav,
Yeah,
please.
any questions, dear participants? Please put on chat box. Vairav sir, you can unmute your mic.
If there is any questions, Vairav, please read.
I'll just look at the chat box. So far, no questions in the chat box, sir.
Okay.
So, any questions from the participant side?
It's okay. I think everyone is clear.
No questions in YouTube.
Is there any questions in YouTube, madam?
No, sir, no questions in YouTube.
Okay, we will conclude then.
Okay,
Thank you, Hiral, for a very good session regarding interpretation of ABG and PFT. And I thank you for registering with us and participating in first day itself. That shows your confidence. So I thank you, and I thank all the participants, and I thank Dr. Vairav, Dr. Sendil Kumar for his presence today, even in his busy schedule. And I thank Professor Duna and Dr. Rupesh. I thank everyone. We will meet tomorrow by 5 p.m. in For the Students, by the Students episodes by tomorrow evening. Bye all. See you.
Thank you, sir.
Thank you. Thank you so much.
thanks, Hiral. It was a nice session from you.
Thank you so much, ma'am.
See you in next session.